Welcome to the Health Workforce Technical Assistance Center's webinar series. This presentation is entitled Data, Methods, and Tips for Health Workforce Supply and Demand Modeling, and it was presented by Tim Dahl on May 14th, 2014. Now, before we get started, I would like to take a few moments to introduce to you today's speaker. Tim Dahl is a health economist in the Life Science Division of IHS. He has over 20 years of experience in healthcare research and policy. Presently, his team is developing an integrated health workforce simulation model to model supply and demand for the National Center for Health Workforce Analysis at HRSA. The model features more than 25 health professions. And at this point in time, I'm going to go ahead and turn the event over to our presenter, Tim. After the event, you may ask questions using the chat panel on the right of your screen. Make sure you send your questions to all panelists to ensure that they have an opportunity to be answered. Also, when the event ends, you'll be directed to a short evaluation survey. So please take a few moments to provide us with your feedback. Tim, you should be good to go.
Great. So the goals of my presentation are threefold. One is I'd like to just describe different approaches that have been used historically, give a little bit of history on different approaches to modeling demand at the national, state, and local levels, and discuss some of the advantages and disadvantages of these approaches and how things have evolved over time. I'd like to also discuss data sources and then share tips and best practices to ensure study success. In the 20 years that I've been doing this, I've probably made pretty much all the mistakes that have been made or that could be made, or I know someone that has made those mistakes. And so hopefully, if you're doing this kind of work, you can learn from my mistakes. So the agenda, first I want to talk about some terms and definitions just to make sure that we're all on the same page in terms of the language that we're using. And then I'll walk through some information on demand modeling, again, the evolution of workforce modeling and some of the advantages and disadvantages of different approaches and data and methods. And then I'll do the same thing with supply. As an economist, I've been trained to talk about supply before demand, but over time I found that demand modeling is actually a little bit simpler than supply modeling, and so I'll go with the easy one first and talk about demand before supply. And then at the very end, save some time for just tips on workforce success. So the first terms that I want to talk about are healthcare services. The work that we do, we tend to use to talk about demand for healthcare services, but there's three definitions I'd like to review: demand, utilization, and need. Because I find that as an economist, sometimes when I'm talking about the demand for services, the person I'm talking to in their mind might be thinking more based on need. Demand might be defined as the amount of healthcare services that people are able and willing to use at different price points. So they're taking into consideration how much is it going to cost me to get this service. Utilization is actual use, and often we will analyze utilization based on analyzing medical claims data. And I just would note that utilization and demand are not necessarily the same thing, in the sense that sometimes people might demand services, but because of supply constraints, they can't get to see a doctor, and so the demand goes unused. And then we have need, and need is essentially an informed opinion on the level of services that might be appropriate. Usually this need is defined by clinicians based on best practices or some other criteria. And again, need and demand are not the same thing, in the sense that many needed services go unmet, and sometimes services that are provided are not really needed. When we talk about workforce requirements, requirements is a kind of a generic term that describes the number of people or full-time equivalents, or how many workers do we need. And when we talk about the demand for health workforce, we're talking about the number and mix of health workers needed to meet the demand for services, whereas if we're talking about the need for health workforce, it's, again, an informed opinion on the number and mix of workers that would be required to meet the need for services. And sometimes we think about need in two ways. What is the minimum need? This might be consistent with HRSA's the shortage designations. where they say what's kind of a minimum threshold that we use to define a shortage area. And then need can also be determined based on best practices, where a panel of people take into consideration the epidemiological needs of a population and best practices in terms of how to deliver those services, and come up with the number of clinicians that would be needed to adequately serve a population. More definitions here. On supply, we might talk about 3 different types of supply. There's the licensed supply, which is essentially people who are eligible to work. There's the active supply, and this would be people that are either employed or seeking employment in an area that would use their clinical skills and knowledge. So, for example, if we had a physician who left clinical practice and became a businessman, that person would not be considered active supply in the sense here. Then we have a term which we call full-time equivalent supply, an FTE, and this is essentially a standardized unit of supply where we take into account that some workers are working part-time, others are working full-time. And in my experience working with HRSA and other groups, we sometimes use different definitions for an FTE based on the available data. So for example, when we might model nurses, if there's a question in a survey that says, are you full-time or part-time or not employed, we might say, okay, let's count a full-time person as 1 FTE, a part-time person as a half FTE, and then we can get total FTEs. In other instances, we might have data on actual hours worked, and some work that we've done recently, we've defined an FTE as the average patient care hours worked among providers, given that they're working at least 30 hours per week. So there is no set definition of an FTE, and it sometimes varies based on the data that you have available. But when we compare supply and demand, we need to make sure that it's an apples-to-apples comparison in terms of the unit of measurement. When we compare supply and demand, we sometimes refer to this as the adequacy of supply. And if we talk about a shortfall, that just simply means that demand exceeds supply, or surplus where supply exceeds demand. Now, the terms shortfall and surplus are sometimes loaded terms, and people might try and get around that by, instead of saying a surplus, we might just say we have excess supply, but it means the same thing. And then if supply and demand are relatively in balance, we might say they're in equilibrium. Essentially, that supply equals demand plus or minus some percent, 5%, 10%. There's no set standard. But the one thing about equilibrium is if it's not in equilibrium, you tend to know about it, that people are complaining that they're having trouble accessing provider services, or in the case of nurses, over the past decade that they were working really long hours. And you start to see these indicators that things are not in balance. But if they're roughly in balance, then you tend not to see indicators such as limited access to care, rapidly rising pay, and complaints about really long hours worked. And then the last definition is just about models, since we're going to be talking about modeling today. And I'll just note that a model is a mathematical framework. It's a set of equations. It's a simplified version of reality. And so often there are either supply or demand drivers that people will acknowledge might be in a model, but because of data limitations, we don't put them in a model. And it just reflects that a model is, again, a simplified version of reality. So to talk about demand modeling, there's three areas that I'd like to cover. One is the drivers of demand for services, and then modeling approaches, and then the inputs and data sources. When we think about the drivers, there's the basic ones, epidemiological factors, which is either need or perceived need, and these tend to be correlated with demographics and in particular age. So when we look at the future demand for healthcare services and providers, age is usually the predominant factor, the growth and aging of the population. But there's other factors that should be considered, both looking at forecasts over time, but especially when making comparisons across geographic areas, and that is disease presence and other health risk factors such as obesity and diabetes. These can vary substantially across regions and across communities within a region. We also think of price and socioeconomic factors, the ability and willingness to pay as drivers of demand for services. Some of the work that we found is that once you control for whether a person has medical insurance, then the correlation between use of healthcare services and economic measures such as household income, they largely disappear once you have control for having medical insurance. Characteristics of the healthcare system, in particular the reimbursement rates, can have a large impact on the demand for services of certain types. We've seen this, for example, with home health. And anyone who's modeled home health and home health aides and home health workers in general know that Medicare reimbursement rates can have a very substantial impact on the use of those types of services. There's also other things, other characteristics like provider-induced demand in defensive medicine, which we tend not to include in our modeling approaches, in part because it's difficult to quantify those. And one of the characteristics of your forecasting demand for services is you need to be able to identify trends in demand drivers. And it's sort of difficult to find trends in, or at least forecast trends in some of these drivers of demand for services. Similar technology, we know that technology will affect the future demand for services, but it's somewhat difficult to quantify. Some technology will expand treatment possibilities, thus increasing demand for services, while other technologies might make it possible to forego certain types of services because of better preventive care or, for example, minimal invasive surgery, which might reduce the demand for inpatient care. And then societal norms and expectations are also demand drivers that we know that they've evolved over time, and some of the norms are that we expect more from the healthcare system. When we think back, for some of those on the phone that might be a little older, if we hurt our leg, our parents would tell us, okay, just sit on the couch, you might sit on the couch for a day. And nowadays, if you don't take your child to the hospital right away to get an x-ray, you might be considered a bad parent, at least by your spouse. So when we look at the drivers of demand for healthcare providers, of course, the demand for services is the predominant driver in terms of the mix of services by condition and care delivery setting, the complexity of services, that when you take into account scope of practice and other provider characteristics, that's how you convert the demand for services into demand for providers. But there are definite changes in scope of practice that have occurred in recent years and are likely to continue to occur into the future. And then also, of course, cost and relative value, that there are many things that a physician assistant does that a physician can do, but that doesn't necessarily mean the physician should do it. So those are kind of the demand drivers. So when we look back historically about how workforce demand or just workforce studies have been done, both in terms of demand models and needs-based models, in this slide right here, if you look at the bottom in the middle under Geminic, back in the 1970s, much of the workforce kind of requirements analysis that was being done, they referred to it as manpower studies back then, was based on expert panels, usually physicians, where they would also analyze some data. And they were needs-based models in the sense that they might say, how many visits should a patient be having over the course of a year, and how much time should a physician spend with that patient? And from those studies, they determined basically the level of physicians and providers that the nation needs. Going up to the demand models in the top left corner, in the early 1990s, Jonathan Weiner looked at the growth in group and staff model health management organizations, HMOs. And I know talking with him, he had a small contract with Hearst at the time and looked at staffing patterns and came to the conclusion that if HMOs became predominant in terms of the number of people served, that we would probably need more primary care physicians and less specialists. And his work had a big influence on some of the work that was put out by COGME in the 1990s. In the early 2000s, Richard Cooper, Dr. Buzz Cooper, came out with a trend model that received a lot of attention, and I have a couple slides later that talks more about that. But what he was doing was looking at correlations between certain demand drivers, in this particular economic drivers, and his measure of demand for services. Also, in the evolution of demand models, in the 1990s and until recently, HRSA and many other groups had what we might refer to as kind of macro-simulation models, population-based models, where we would divide the population into demographic groups, look at the use of services for each of those demographic groups, and then model the implications based on changing demographics. Over the past year and a half, the Center for Workforce Studies in Albany, New York, and my colleagues and I here at IHS have been working with HRSA to build a new forecasting framework which uses a microsimulation approach. This is an approach that my colleagues and I have been using now for several years, predating their work with HRSA. And I'd also note that Erin Fraher and her colleagues at the Shep Center also have been building a microsimulation model focusing on the physician supply, the Future Docs forecasting tool, which on the supply side has about 35 physician specialties, and on the demand side looks at about 19 clinical service areas. The microsimulation models have some unique characteristics, but the main difference between the microsimulation and the macrosimulation is that we're modeling at a person level, and so it provides much more flexibility to model policy changes and the evolution of care delivery models. I would note that for needs-based analysis, anything that's demand-based can often be converted to a needs-based analysis by running different hypothetical scenarios about what a population might use if the uninsured became insured, and if disadvantaged minority groups had utilization patterns similar to non-Hispanic white populations, and so on, that you can do that needs-based analysis. So this slide right here is kind of a combination of the benchmarking approach and the demand-based approach that uses kind of a population approach to modeling. And this is a chart that my colleagues and I put together for the primary care report that HRSA published last year. And what you can see here is for the population age 0 to 5, they currently use about 225 full-time equivalent primary care practitioners per 100,000 population. You can see the bulk of those are pediatricians and nurse practitioners, with a few in the other primary care providers. Contrast that with the population age 18 to 20, where you need only about 50 full-time equivalent practitioners per 100,000 population, with the majority of those being general family practice and general internal medicine. This just shows you right here that the current utilization patterns, if we extrapolate those into the future, that with a growing elderly population, the demand for primary care providers will grow substantially because of just the aging of the population, and that much of that growth will be for general internal medicine and general family practice. Now, the geriatric medicine also grows substantially in percentage terms, and a large portion of care that currently is provided by other primary care providers could be provided perhaps by geriatrician. This just reflects if we take current patterns of use and care and extrapolate those to the future. I would note that even within a demographic group, there can be substantial variation in use of services. So in this example, if you have a non-Hispanic black female aged 75 or over, insured with diabetes and with hypertension and obese, that for a population like this, you would need about 26 full-time equivalent primary care physicians, this is just physicians now, per 10,000 population. And if you contrast that at the bottom bullet with a non-Hispanic black female, this time only age 18 to 34, insured, no diabetes, no hypertension, normal body weight, that for a population like this, you would only need about 2.4 full-time equivalent primary care physicians per 100,000 population. So it just shows that both demographics and also other risk factors can be big drivers in demand for services. Now, I want to go back to the other approach, the trend approach or the correlation approach, and just give an example here of Dr. Cooper's work that was published in Health Affairs in 2002. Now, Dr. Cooper's hypothesis was that the healthcare system is really too complex to try and model, and so you should find a handful of key drivers and just focus on those. And in his opinion, the key drivers were population and economic growth. And he showed a fairly strong correlation over the, well, since between 1929 through approximately 2000, well, about 2000 is when his data stopped, showed a fairly strong correlation between the active physicians per 100,000 population in the U.S. and also the gross domestic product per capita. Other work that he did also showed strong correlation when you looked across countries and across geographic areas, that wealth was associated with more physicians per capita. What was a little unclear to many of us was that just an indication that people with money to spend were buying more healthcare services, or was it simply that physicians were going where the money is? Probably a little bit of both. So I did my own trend analysis. It's kind of a little bit of a parody of the Cooper one, where I actually looked at the per capita consumption of apples and looked at the physician to population ratio and the correlation with that consumption of apples. Now, there is a slight downward trend, as you can see in the red line, and each apple, and a typical apple weighs about 5.2 ounces. So if a person ate an apple a day, that would be about 119 pounds of apples per year. And if you extrapolate this line all the way out to 119 pounds of per capita consumption of apples, the physician to population ratio actually goes to 0. And the key implication was that an apple a day does keep the doctor away, and that consumption of 118,000 apples would reduce physician demand by 1. Now, clearly this was this is not happening, but it just goes to show you that you need to be very careful with correlations, because you can find a correlation, but it doesn't help you interpret policy or help you in planning. Okay, so some of the limitations of the historical approaches to modeling using these population-based ones, the main problems with them were the inflexibility in modeling changes in policy and modeling changes in care delivery patterns. Now, they did use historical data on healthcare use patterns and healthcare delivery patterns, but relatively little flexibility to modify those to be forward-looking. Often they had few demand drivers. They might include things like demographics and insurance status, but using population-based approaches, you couldn't incorporate things like diabetes prevalence rates and other health risk factors like smoking and so on, and obesity. Also, that they often relied on key assumptions. In the case of Dr. Cooper's, it was about economic growth. In the case of the benchmarking with the group staff HMOs, it was about HMO growth. So those were limitations of those approaches. Limitations of approaches that used expert panels are that there could be potential bias. The physicians think that care should be delivered in one way. The nurse practitioners might have different ideas about how care might be delivered. And so there are limitations to those approaches. Building on those limitations, this is why we and HRSA and the folks at the Shep Center have started building microsimulation models. These models are fairly complex in the sense that there's a lot of moving parts, and there's a large investment that goes into building them, but they become more powerful tools for workforce modeling. And I'll briefly describe the HRSA's workforce model, just noting that there are a lot of overlap between that and, for example, the work that the Sheps is doing and IHS. But you start off with a population database, and in this population database, you develop a profile for a representative sample of the population that you're interested in modeling. Demographic information, socioeconomic, and various health risk factors. And I'll go into that in more detail in a moment. You look at utilization patterns that relate the demand for services, or sorry, the use of services to patient characteristics. That gets you the demand for services. You model the staffing patterns to convert demand for services into demand for providers. And with the HRSA model, because it covers approximately 40 health professions and approximately 36 medical specialties, it's looking at inpatient care and emergency care in an ambulatory setting, provider offices, outpatient clinics, dental, nursing facilities, residential care, home and hospice care, and in other settings where nurses and other workers might work, like in school health and academia, public health, and insurance companies, and so on. So that's kind of a high-level overview. So developing the population database, the way the HRSA model works is that we take the Center for Disease Control Prevention's Behavior Risk Factor Surveillance System, which has micro-level data on a representative sample of the non-institutionalized population. We take the American Community Survey, which comes from the Census Bureau, which has a representative sample of the population in each state and also at the sub-state level if you combine multiple years. And then we take information from the National Nursing Home Survey. And from that, we create a population for each of the states, and in some cases at the sub-state level. In this slide right here, the way we do it is you take the American Community Survey and divide the people into the institutionalized people and the non-institutionalized people. People who are institutionalized, we match them with someone from the National Nursing Home Survey that's in the same age group, same gender, same demographic group. For someone in the non-institutionalized population, we match them with somebody from the Behavior Risk Factor Surveillance System that's in the same state, same age group, same gender, same race, ethnicity, same household income level, same insurance status, and there might be one or two other things that I can't think of right now. But we try and match them so that we basically now have a profile for these people that includes a wide variety of health risk factors. I would note that in addition, in large part because of changing demographics, just based on changing demographics alone and take into account the characteristics of the current population, as the population ages, we will see the population with a history of stroke and heart attack growing fairly rapidly, same with cardiovascular disease. The population with asthma is going to be growing more slowly because it tends to be a younger population. But what this shows is that the underlying chronic conditions associated with an aging population will tend to cause demand for services in particular settings and also for particular types of conditions, say to a cardiologist or to an endocrinologist, to grow more rapidly than demand in other settings and for other specialties. Analyzing the National Medical Expenditure Panel Survey, we can look at the relationship between the characteristics that we have for a person and their use of healthcare services. This example just uses cardiology and cardiology-related services, and I'll just really quickly summarize some of the areas I've highlighted in yellow. If we take non-Hispanic blacks, they tend to have much lower use of office visits relative to other racial and ethnic groups, but they have much greater use of outpatient visits, emergency visits, and hospitalizations. Males tend to have more use of cardiology services than females, very strong age component, and the presence of anything cardiovascular related, hypertension, coronary heart disease, heart attack, or history of heart attack, diabetes, and so on, that the presence of these is highly correlated with the use of cardiology services. And we know from the CDC data from BRFIS that the prevalence of these conditions can vary substantially across states, and then also within states it can vary across communities, and in many cases it might be correlated with race, ethnicity, or other characteristics such as body weight that are controlled for in the analysis. After modeling the demand for services, the next part is to come up with staffing patterns so that you can map demand for providers into the demand for services. This example right here just shows the distribution of registered nurses and licensed practical nurses across care delivery settings, so that when we model, say, demand for office visits, we know that there's a certain proportion of nurses that are providing care in office visits, and likewise in home health and nursing homes and so on. And as the population ages and grows, and as other trends affect how care is used and delivered, that the rate of growth for, say, nursing home care might be substantially faster than the rate of growth for, say, emergency visits or office visits, simply because of changing demographics, as well as things such as expanded medical coverage and other factors that affect how people use services and where it's delivered. Okay. And this particular example, once you look at these staffing patterns, you can make conclusions such as for every 1,000 ambulatory visits to a pediatrician, it equates to approximately a fourth of a full-time equivalent pediatrician. Or 1,000 hospital rounds equates to approximately half of a full-time equivalent pediatrician. And the data sources come from a variety of sources, national surveys, professional associations, and other reported statistics. So switching to the supply, supply is relatively straightforward in concept, a little bit more difficult to implement in practice. But we start with the current supply, we add new entrants, we take away the people that have left at the year, we have our end-of-year supply, and the process repeats itself over and over as a cycle over the projection horizon. It gets a little more complicated when we want to take into account workforce participation, modeling attrition rates, modeling hours worked rates. For some health workers, they might change occupations. For example, you might have a nurse aide that trains to become a licensed practical nurse, or an LPN that trains to become an RN, that kind of movement. There's some movement across specialties, and that makes things a little bit more complicated, especially when you go down to the state level and people are moving in and out of states. The traditional approach to modeling supply was to use what we might call a cohort or an inventory model, where we have a certain number of people in a cohort. So a cohort might be all nurses that are trained at the baccalaureate level that are age 30, living in a particular state. And we would follow what happens with that cohort as it ages. Usually as it ages, some of the people will drop out of that cohort due to retirement, and some of the people in that cohort might start working fewer hours. And so that cohort starts to shrink over time generally in terms of the full-time equivalent supply coming out of that cohort. These models work pretty well, except that they have limited ability to model certain types of policy analyses, and I'll talk about that in just a moment. But in general, these models have been around for a long time and tend to work fairly well. Okay. The work that we're doing with HRSA, and also similar to the work that the Shep Center is doing on physicians, uses a microsimulation approach to supply modeling, where we're doing essentially the same thing we were doing with cohorts, but now we're doing it with individual providers as the unit of analysis. So you might start off with a licensure database and drop all the people in there that are not currently active, and that becomes your starting supply. And for each person, you would simulate from one year to the next the likelihood that they would remain in the workforce, and the likelihood, or the number of hours that we think they might work based on either historical patterns or hypothetical scenarios. But essentially, for each person, you're simulating career choices about specialty, location, hours, and retirement, and those can change over one's career. And they can also change in response to external factors such as how what's happening in the economy. We know, for example, that for nurses, for registered nurses, their labor force participation patterns often tend to be counter-cyclical, that when a spouse maybe loses employment, that a nurse who was out of the workforce might come back into the workforce, and so those external factors can play on things. And then we model new graduates coming in by essentially creating a new individual, such that the characteristics of the new people entering the workforce reflect the distribution in terms of age, gender, specialty, and occupation of people that are moving into the workforce. Strengths and limitations. The main benefit of the traditional or the cohort approach is that it's simpler and it has fewer data needs. The main benefits of the simulation model is that because of its complexity, it's more flexible for modeling trends trends in policies, or trends in supply determinants, and modeling policy and helping to inform policy. And it becomes a more dynamic model in the sense that you can allow things such as economic factors and other external supply drivers to affect the supply. Whereas the traditional approach can be done in something like an Excel spreadsheet, with the microsimulation approach, you need a more specialized, more powerful software, something like SAS, which is often used. Some of the supply-related data sources, state licensure databases are some of the best data sources. They take some cleaning, but very valuable information. National and professional surveys. The American Community Survey has really good data for health professions other than physicians because it doesn't have physician specialties. HRSA has a nurse practitioner survey that soon will be made public. The Association of American Medical Colleges has done periodic workforce surveys, and individual professions have done surveys. Also licensure databases, they tend to be not quite as clean as, say, state licensure files, but also a good source of information. There's the NCCPA master file on physician assistants, which is a fairly new file, which has a wealth of information that's being collected. And there's also information from education systems like iPads for the training of some of the technician, technologist types of health workers. With the microsimulation modeling and also with the traditional cohort approach, you need to analyze things like retirement patterns and hours work patterns. We've done this in a couple of ways. One is using what we call regression analysis, where you look at people's workforce participation patterns or their hours as a function of their age and their gender and maybe their education level and perhaps other characteristics associated with where they live or the healthcare system in their area. The American Community Survey is a good source of data, and then again, survey data that's such as those that I mentioned before, collected from a variety of sources. This slide right here shows hours work patterns for primary care physician specialties. So this includes pediatrics, general family practice, general internal medicine, and geriatrics. This information happens to be from Florida's survey. Florida, like many states, has a survey that's part of the relicensure process and collects a wealth of information there. We can see that that patient care hours worked for these specialties differ by age group slightly, but also differ for male and female physicians. This slide right here shows retirement patterns. These retirement patterns were actually calculated using the AAMC's 2006 survey of physicians over age 50, where they asked both, have you retired, or if you hadn't retired, at what age do you intend to retire? And what we find is that many people intend to retire, say, between age 60 and 62, between age 64 and 66. So if you say, at what age do you intend to retire, they kind of give what we might call these benchmark dates that I'm going to retire on, when I turn 65. But in reality, they tend not to retire quite that quickly, whether because they decide that they want to stay in practice, or they have trouble selling their practice, or they just, for whatever reason, they tend to work a little later than they indicate their intention to retire when you look at historical patterns. This graph right here is again based off the Florida survey of physicians, and like Florida, many states will often ask a question, do you intend to retire in the next 3 years or the next 5 years? These patterns right here are based off a question of, do you intend to retire in the next 5 years? And then we also incorporated mortality rates from the Centers for Disease Control and Prevention. What we found was that the intention to retire retirement rates were fairly consistent with the data from 2006 by the AAMC from their survey, which I think is a good sign. Okay, so just a few slides left here. Some resources. One resource just to be aware of is that HRSA, we're working with HRSA to build a web-based version of the nursing workforce model, nursing supply and demand, and we're hopeful that in the next couple months that will be started to be beta tested by selected states. But the goal is, once that has been beta tested, to make it available to other states. The rationale here is that states often have the best source of data for something like nurse supply because they collect it through the licensure process, where they can upload information from the licensure database and then do their own supply and demand analyses. So that's something to look forward to, but I can't commit on a date. So if anybody asks me during the Q&A what the dates are for that, sorry, but there's no set dates just yet. So tips for a successful study. So this is based on my experience and often bad experience when some of these things weren't done. One is up front to have clearly defined goals for the study. Are you primarily interested in forecasting, or are you also interested in policy analysis? Because if you're just interested in forecasting, say on the supply side, you might go with a simpler approach than if you also want to be able to model policy. I think it's very useful to involve an advisory committee that includes clinicians. They often have great insights very useful. I would say beware of small specialties. You run into all kinds of sample size issues. And so when we model physician specialties, for example, we tend to group them into kind of manageable sizes, because if you get too small, it just creates all kinds of complications. Give the supply data a thorough cleaning. When you look at state licensure databases, you will often have people who are not practicing in the state. You might find people that just moved into the state and got a license at the age of 70, and you're wondering, what is this 70-year-old moving into the state now and getting a new license? Are they really practicing or not? You might have locum tenens or other people who are doing, say, telephone-based care, where for whatever reason they need a license in the state, but they're not actively practicing in terms of being a significant portion of a full-time equivalent. As you develop models, do sensitivity analyses and stress tests, and use the peer review process to see if your proposed approach and your findings make sense. And then I would just note that models and projections constantly need to be updated as new Census Bureau population projections and other data becomes available. So that's the presentation. David, back to you.
Thanks, Jim. That was a lot of good information. And at this point in time, we're going to open up things to a Q&A session. Once more, if you have a question, use the chat panel on your right of your screen to ask it, and direct your questions to all panelists to ensure that they have an opportunity to be answered. Okay, Jim, first question. How do you deal with lack of data for local area analysis for microsimulation?
I thought, was that lack of data?
Yes.
Lack of data. Okay. That's often a difficult challenge. Sometimes what we do, like if we want to model, say when we did a study for Arkansas and we wanted to model the characteristics of populations in rural counties, what we did was we took the database we created using the BRFIS and the ACS, and we took only the people that were in non-metropolitan areas, and then we took other information from CDC that had aggregate information on things such as rates of asthma and diabetes and smoking and rates of uninsured for the different counties, and we reweighted our population sample so that it looked more like the county that we were interested in modeling.
Okay, Jim, thanks. Next question. Are there recommended margins of error to consider as a way to gauge who is actually practicing?
That's a good question. What I found from analysis of files such as the AMA master file and also state licensure databases is that there's quite a few older physicians who the file indicates that they're active, but the age distribution doesn't conform to patterns of retirement. So for example, let's suppose that retirement patterns were such that no one worked after the age of 90, but yet we see people in their 90s that are still listed as active in the files. That makes you think something might be wrong. What we have done sometimes with the AMA master file is we run a year of the projection to retire off some of the older people, and then the age distribution looks more like what one would expect based on patterns of retirement. And I don't know that there is any margin of error, so to speak. This is part of the art that goes along with the science, but there does seem to be a lot of people, especially among the older groups, older ages, that are not active even though they're listed as active. Now, the AAMC 2006 survey of physicians over age 55 or over 50, they purposely sampled physicians who were listed as retired in the AMA master file, and also older physicians who were listed as active, and they asked them, are you really active or not? A large portion of the ones that were listed as active in the AMA master file were not active, or at least they were only maybe working a few hours a week, but not the definition that AMA uses, which is 20 or more hours per week. But we also found some listed as inactive in the master file who indicated that they were still in practice. But the larger direction was that they were not active.
Thanks, Tim. Here's a couple questions. For the nursing workforce model, how would a state go about participating in the beta testing of it? And also, what states are you working with for the nursing workforce data?
Okay. The states haven't been set in stone, but I know that the New York Center is one of them, simply because they're our teaming partner on the work with HRSA, but the other ones haven't been determined yet. And it's more based on a matter of interest. We don't want all the states to participate in the beta test because, the purpose of the beta test is to work out some of the bugs so that then the other states can have a cleaner model to work with. But I would say if you want to contact the center, Jean Moore in particular, and kind of filter through her, then we can approach HRSA with it. But it's one of those things where we're looking for only a handful to participate in the beta test, but then it will be open to everyone.
Thanks, Tim. With regard to the supply of primary care providers, does the microsimulation model or any other model approaches take into account primary care provided by specialists, e.g. an oncologist partly providing primary care? Well, the models, sometimes I wonder if that should be a demand question versus a supply. But when a person goes to, say, a cardiologist's office, we know that some of the services being received are specific to cardiology, and some of them might be what we call general primary care. And in particular, for some of the specialties like rheumatology and even maybe OBGYN, where people use that person as their primary provider because of a chronic condition, they do start to take on the role of a primary care provider. In the supply projections, we tend to just report supply in terms of the traditional recognized primary care providers. But one can take the supply of other specialists and based on other outside research say a portion of their services are really primary care. But it's not actually done inside the model. It's something that you kind of do after you run the results and do kind of in a spreadsheet. I do know that the center, the Albany Center for Workforce Studies, has done some work with nurse practitioners looking at the proportion of time that they spend doing primary care. And there is, among nurse practitioners, a substantial proportion of time spent in a specialist office is actually providing primary care. Thanks. What web-based workforce modeling is readily available for forecasting?
I don't know that any is readily available. I know that the Shep Center on the physician side has been working on an open source model, and I'm not sure the exact status of that in terms of it being open to others, but I know that it's been a goal of theirs. And again, on the HRSA side, there's a desire to, well, we're working on the nursing component only. IHS is also doing the web-based one, but it's still in development. I don't know of any others that are readily available.
Next question. What population characteristics do you need to apply the demand model to a local area, and do you need joint combined attributes of all factors?
Well, the more information you have, the better, and it's useful if they are joint combined, because it gives you a better reflection that sometimes, for example, someone with diabetes and with cardiovascular disease might be worse in terms of their health than someone with just one of those conditions and not the other. Sometimes when we do work at the local area, we might not have good information about a particular variable, and what we do is we try and reweight our population so that in the aggregate, at least our population is matching aggregate numbers.
Okay, Jim, in your experience, how has this kind of data been shared with relevant stakeholders, particularly educational institutions, and to what extent, if at all, has this type of modeling been used to encourage more people to become health workers?
Okay, so I was involved with HRSA's work back in 2004 when we were forecasting that there would be a shortfall of 1 million registered nurses. It seemed like in the years after that, and it was recognized by many, not just HRSA, that there was a shortage and that things were likely to get worse. I know that the Robert Wood Johnson Foundation and Johnson & Johnson, many institutions, states were pouring a lot of money into encouraging people to consider nursing as a career, expanding nurse capacity and education. And it seemed like everybody that I knew was going into nursing. And I started to get a little worried, saying, what happens if we overshoot here and there's no jobs for these people? Because, over the past decade, we doubled the number of people coming out of nursing programs. So I know that these projections can help influence policymakers and others about choosing a career. And when we do forecast, we need to take into consideration that we want to make sure that the nation has adequate access to future services. We also want to take into consideration that if a person puts substantial time and money into their career, they want to have a fruitful career, which places a strong emphasis on getting it right, not overshooting or undershooting in terms of supply relative to demand. And I think that's one of the reasons why workforce studies need to be updated more frequently, because if we think back to COGME, the Council on Graduate Medical Education, they went 10 years between major reports. They went from saying that we were going to have too many to too few specialists, but over their intermediate time, most people in the workforce community knew that things were changing. It's just that the reports took so long. It was so long between reports. I think by building some of these models, like the new HRSA models, where it covers multiple occupations and specialties as opposed to siloed models, that they're easier to maintain, which means they can put out projections more frequently, and it can be done more efficiently at lower cost, and that it can provide better information to give people more accurate representation of should I choose this career or not, and in the case of institutional education, are we training too many, are we training too few?
Okay, next question. How does this information translate to policy? Example, should the HWTAC designation be changed since it is shown to be a limited measurement of the workforce? Should policy be based on the more advanced models?
Yeah, that's a good point. With the HWTAC designation, one of the challenges over time is that some of the states that had few resources were somewhat disadvantaged in trying to get their designation because they had relatively few resources to go out and go through the process. And one possibility is to use these more sophisticated models to basically bring the work in-house into HRSA, where they could forecast what the demand is for services and compare it to supply, and take into consideration more needs than is currently being considered. I think HRSA is considering things like that, but I don't want to put words in their mouth, but it's something to consider.
Okay, Tim. Do you ever consider special types of health providers, such as community health centers that might practice differently and serve different populations?
Well, good question. For certain types of providers like community health workers, their scope of practice and their role continues to evolve over time. And with the emergence of accountable care organizations and a desire to do greater outreach and greater coordination of care across delivery settings, these roles will continue to be refined. And again, this just goes back to we need workforce models that can quickly be updated and refined as scope of practice and care delivery models change. Right now, often we don't include, say, community health workers and nurse aides and so on in some of the analyses, in particular on the supply side, because of the low barriers to entry and exit into the workforce, that sometimes they're very difficult to model because of that ease of entry and exit. And so on the supply side, we tend to focus on those professions where there's a long training pipeline and they're very expensive to train. On the demand side, there's more flexibility to model those types of workers.
Okay, Tim, last question, then you're off the hook. In your ideal world, what is the minimum data about the workforce that states should collect to be able to do good modeling? Well,
there's kind of two levels to that question. I mean, the minimum would be things such as just knowing for your current workforce, age, gender, specialty, occupation, and location. I mean, those are the minimum things that you need. Nice things to have would be collecting information on hours work patterns, on intention to retire, at the state level, intention to move out of the state, or if they're licensed in the state, intention to maybe to move into the state. Some of the challenges we've had with modeling at the state level have been getting a good grip on the supply of new entrants to the workforce, because you have people that are coming out of medical school, and for example, physicians who might get a license even though they don't intend to stay in the state after they finish medical school or after they finish their graduate medical education. And likewise, you get people that move to the state and they get a license even if they don't intend to practice. And so when we're trying to forecast future supply, it's sometimes a challenge to figure out of those new entrants who really does intend to work in the state and who doesn't.
Thanks, Tim. I think that was a great presentation. And thank you out there for attending our webinar. Just to let you know, we will be posting our slides shortly to our website. So if you want to download them, check back very quickly at healthworkforceta.org. We hope to see you again in the future. Thank you, and have a good day.